Hi, this is a video lecture on the introduction to fetal monitoring. We know that you have this in class. However, we felt that this resource would be available for you for test taking purposes, as well as your use in the clinical setting, as well as help prepare you for the upcoming fetal heart rate simulation. So, when we're talking about fetal heart rate assessment or electronic fetal monitoring, what we're doing is we monitor both the uterus and we monitor the fetus and its relationship to each other. We look for abnormal patterns that could possibly suggest hypoxemia or even worse, hypoxia that could lead to respiratory and metabolic acidosis. It is routine in the hospital setting in this country. However, continuous fetal monitoring has been consistently shown that it does not decrease the risk of cerebral palsy or help decrease the risk of neonatal mortality as once thought. So it's more of a medical legal type of thing that we do. And it does give us some clues on how a fetus is doing during labor. So, for starters, we monitor both the uterus and the baby, and we can do both of them externally or internally. So, going along with your PowerPoint, you can see on the bottom picture where you'll see the belts that are wrapped around the woman's abdomen. The bottom one is usually the ultrasound, and it picks up ultrasonic waves. And then it presents onto the strip. The top one is a toco transducer, which there's like a little button, and the pressure of the contraction tells us how frequent a contraction is. It does not tell us how strong it is, it tells us how frequent it is. The upper picture has two things in it. One, there's an intrauterine pressure catheter that you can see kind of floating in the abdomen. And that is the only way that you can tell how strong a contraction is, because it picks up the millimeters of mercury. There is another one that actually is a spiral electrode that goes into the baby's head, and that picks up like a direct EKG of the baby. So therefore, you're going to see that there is the fetal heart rate as well as the uterus. So right here I have this little strip. The top channel right here is the fetus. The bottom channel right here is the uterus. Okay? So that is part of that. So we're going to be looking at baseline, we're going to be looking at variability, and we're going to be looking at accelerations and decelerations. So we know that the normal fetal heart rate baseline is 110 to 160. So when you're going to change a baseline that, let's say, that's less than 110 for 10 minutes is now bradycardic. A baseline that has changed after 10 minutes that's greater than 160 is called tachycardic. And there's many reasons why a baby might be tachycardic or bradycardic. And probably the number one reason for tachycardia would be maternal fever. So we know that for a case. Also, fetal activity as well as caffeine ingestion by mother. I had a patient one time who had drank like a 2 liter of Mountain Dew, and this fetus had sustained tachycardia. So I've never actually forgotten that. Bradycardia could be that the baby's hypoxic, maybe mom's dehydrated, she's hypertensive. So therefore that kind of reacts to the baby. So those are some of the reasons for fetal tachycardia and fetal bradycardia. What is variability? Variability is this saw-like appearance. It's these fluctuations. And basically what it is, it's a tug of war between the parasympathetic and the sympathetic nervous system. So it's this tug of war. So we know sympathetic is speedy and parasympathetic is pokey. So it's this tug of war that gives us this variability. Now, when you're looking at when you're trying to determine variability, when you look on your PowerPoint, there's 3 strips. There's C, B, and A. You can see in letter C, that's moderate variability. That tells us that we have an intact autonomic nervous system, and that we probably have a baby that's not hypoxic, and we probably have a baby with a normal acid-base balance. Moderate variability is the single most important indicator of fetal well-being. Now, the next strip below it, B, is minimal variability. Minimal variability doesn't mean necessarily that the baby's hypoxic. However, it could be. So there is normal 30-minute sleep cycles for a fetus, okay? And that's when minimal variability happens. Or mom maybe has taken Stadol in labor. That would cause minimal variability. So that is why we have to have a really reassuring strip before we give narcotics in labor. So if you have a woman who comes into your triage unit and she has minimal variability, you can't just safely assume that the baby's sleeping. You have to determine whether or not this baby is hypoxic or not. Followed by strip A, which is absent variability, which is a very severely compromised baby. So again, C is the one that we want. B doesn't necessarily mean it's bad. A kind of does. You have to look at the company that what it's keeping. Okay. All right. So in antepartum lecture, we talked about some of the tests of fetal well-being. A non-stress test is one. And basically, you want it to be reactive. So you can be reactive, non-reactive, or equivocal. A reactive non-stress has these parameters that are listed on your PowerPoint. A normal baseline. What's not listed here is moderate variability, 2 accelerations in 10 minutes, and no decelerations in the fetal heart rate. So you can see the accelerations, and then you can see that there's no decelerations. So you look at the uterus and see if there's any contractions and what's happening with that. Accelerations are always okay. Look at the VEAL-CHOP acronym that we talked to you in class about. So a reactive non-stress test. A non-reactive non-stress test basically means that it didn't meet criteria, like maybe it had 1 acceleration or no accelerations, but it had moderate variability. So we can call that non-reactive, or we can call it equivocal, where it's not bad, but it's not good. So there's a lot of room for interpretation with this, but for your purposes, a reactive non-stress test has these that are listed on your PowerPoint plus moderate variability. Now getting into decelerations. Decelerations, the 3 that we're going to be talking about is early, variable, and late. Moving right into early variable decels, you can see where the contraction is starting to increase. That is when the heart rate is starting to decrease. You get to the peak of the contraction, that is where the peak of the deceleration is. Therefore, and then as a contraction starts to lessen, the fetal heart rate starts to recover. And it's by the end of the contraction, the fetus has recovered completely. Now, it mirrors the contraction. It's benign. It is caused by head compression. So as that head is starting to come down, pressure is put on that. So there's no intervention is needed. However, you still document that they are early decels, but again, they are benign. The next one is variable decelerations. Variable decelerations are not to be confused with variability. Okay, so variable decelerations can happen with a contraction or without a contraction, hence their name, variable. Whereas with an early decel, and what we're going to talk about here in a second, late decel, you have to have contractions associated with them. The most common deceleration is variable deceleration, and that's because you learned that with amniotic fluid function, and one of those functions is to cushion the cord. So as you get further in your pregnancy, at 40 weeks, the fluid starts to dissipate, so therefore that fluid, that cushion is kind of removed. If you break your water, that fluid, that cushion has changed. So therefore, the cord is being compressed at some point. So why during a contraction, with the pressure of the uterus, it does compress the cord, but it's not so much cord compression per se for a variable deceleration. There's some reason the cord is being compressed, either because of the decreased cushioning, maybe the baby's holding onto the cord, maybe the cord's around the neck, maybe the baby's leaning against the cord, so hence the name variable. It can happen with contractions. It's a pull down. So I always say if you can put flowers in it, it looks like a vase. That's a variable deceleration. It's a quick drop and an even quicker recovery. And probably the biggest thing that we need to do is change mom's position because of we want to decrease the compression on the cord. Excuse me. Late decelerations are our next deceleration that we're going to talk about. And this is our most ominous one. Again, disruptive of fetal oxygenation due to uteroplacental insufficiency for whatever reason. Maybe they're hyperstimulated, they're having too many contractions, so they're not having this rest period that's so important right here. So when they're contracting too much, they're not able to kind of replenish their oxygen reserve. There might be post-term pregnancy. The placenta gets old and it doesn't, it's more hypoxic and malnourished, and it's not giving that baby what it actually needs. So for whatever reason, mom's laying flat. Mom maybe just received an epidural, and so that's a transient type of late deceleration. But again, look at the company it keeps. If you have like absent or minimal variability with late decelerations, you might be a little bit more concerned. So again, you can see if you turn your PowerPoint to the side, you can see where the contraction starts to go up and the fetal heart rate is stable. It reaches the the peak of the contraction, and now the fetal heart rate starts to go down. Okay, so then the contraction starts to go. That's when the deceleration is, and the contraction's over with, but the fetal heart rate is still down. So therefore, that rest period is not happening because things are still compressed. So that is why we call those late decelerations, and they do mirror the contraction, but they're late. And so again, that's an issue, and that's why we get into intrauterine resuscitation with the acronym called POISE. POISE is position change. O is for oxytocin off, if they're on oxytocin. IV fluid bolus to maybe give some volume. Maybe mom's blood pressure is down. We do a sterile vaginal exam because maybe either there's a cord or maybe she has just really progressed in labor quickly. And then E is evaluate. So everything that you did, position change, turning the Pitocin off and giving the IV fluids, and you checked her cervix, is she still having late decels? If yes, then you need to turn her, you have to do something else. So you turn her to the other side. Now, if the late decels had stopped, then you just go ahead and call the healthcare provider and say, hey, you know what? She was just having late decels. I just kind of, did my little interventions. I turned up her IV fluids. I checked her cervix. I turned off the pit, and everything is fine now. But if it's not, then you need to call them again. So you're going to turn and position as many times as you need to, okay? So those are just some of the things about fetal monitoring that we thought would be helpful for you. Enjoy.